barbiturate overdose more likely. Physical dependence on barbiturates makes continuation difficult for most long-term users and can lead to seizures caused by an excitable rebound of CNS activity. The barbiturates have also been linked to fetal abnormalities and cognitive impairments that are similar to those seen with fetal alcohol syndrome, FAS. Female patients using barbiturates to control seizures or other disorders should be advised to suspend medication early in their pregnancy. Other drugs. barbiturate overdose more likely? Physical dependence on barbiturates makes discontinuation difficult for most long-term users and can lead to seizures caused by an excitable rebound of CNS activity. The barbiturates have also been linked to fetal abnormalities and cognitive impairments that are similar to those seen with fetal alcohol syndrome, FAS. Female patients using barbiturates to control seizures or other disorders should be advised to suspend medication early in their pregnancy. Other drugs with a lower risk of adverse fetal effects may be more appropriate. Finally, combining barbiturates with other GABA agonists such as alcohol can accidentally cause respiratory depression and death. The CO2 sensitive respiratory center located in the medulla contains GABA receptors that regulate respiration in response to increased CO2 levels. Excessive GABA inhibition decreases medulla responsiveness to CO2 and depresses respiration. p. 113 benzodiazepines. The introduction of barbiturates in the early 1900s ushered a promise that drugs could be developed to alleviate symptoms of behavioral disorders by altering brain chemistry. Epileptic seizures, severe anxiety, debilitating insomnia, muscle spasms, and a variety of other ailments were for the first time treated effectively and humanely. Surgical anesthesia, which to this point was induced by vapors of ether or chloroform, was also dramatically improved with the introduction of barbiturates. For nearly 50 years the barbiturates were the choice of treatment for these disorders and for surgical anesthesia. In the 1960s, however, the treatment of anxiety disorders was revolutionized by the introduction of the benzodiazepines that were discovered in 1954 in laboratories at the pharmaceutical company Hoffmann, La Roche. In 1960, the first benzodiazepine was released as Librium, which was quickly followed by Valium. Since then, over 2,000 benzodiazepines have been synthesized and approximately 30 have been marketed for their anxiolytic and hypnotic properties. Not all of these are currently available for use in the US. Once the benzodiazepines became available, they rapidly replaced the older barbiturates and became the most widely prescribed psychoactive drugs in the world. The benzodiazepines all share a common three-ring molecular structure that largely determines their activity. The main differences are the specific molecules that are attached at the methyl, CH3, sites and the Cl site on the rings shown in figure 4.9. Substitutions on the CH3 sites are typically with hydrogen molecules, H or H2, and at the Cl sites typically nitrogen dioxide, NO2. All of the benzodiazepines have the same mechanism of action regardless of their specific molecular structures. The major differences are their half-lives and their fat solubility, which determines how quickly they enter the brain. The half-lives of benzodiazepines can range from a few hours with the ultra-short acting anesthetic burst, midazolam, to several days with the longer-acting anxiolytic Valium, diazepam. The effective half-lives of Valium and most other longer-acting drugs are extended by their active metabolite nordiazepam. Several common benzodiazepines and their respective half-lives are presented in Table 4.2. The longer and intermediate-acting benzodiazepines are typically prescribed for anxiety and seizure disorders, while the shorter-acting drugs are most often used for insomnia and for surgical anesthesia. Figure 4.9. The molecular structure of several common benzodiazepines. All of the pharmacologically active benzodiazepines share a common three-ring nucleus. Substitutions with hydrogen molecules at the CH3 sites and nitrogen dioxide, NO2, at the Cl site are common structural arrangements for many of the benzodiazepines. p. 114. Table 4.2. Several common benzodiazepines and their half-lives. Mechanisms of benzodiazepine action. Benzodiazepines all bind to the benzodiazepine site on the GABA receptor complex illustrated in figure 4.8. As with the barbiturates, benzodiazepines alter the shape of the GABA receptor protein so GABA has a greater affinity for its site. When the inhibitory neurotransmitter GABA binds to its receptor, the chlorine channel opens and allows for the influx of Cl, ions, thereby hyperpolarizing the cell and making it less likely to fire. The anxiolytic and sedative effects of the benzodiazepines are mediated by GABA receptors in the frontal cortex, the hippocampus, and several limbic structures including the amygdala. Because the benzodiazepines do not open chlorine channels on their own, as do the barbiturates, the amount of neural inhibition they can produce depends on the availability of GABA, see figure 4.10. Not all benzodiazepines function as agonists on the GABA receptor complex. The benzodiazepine flumazenil is a potent antagonist of benzodiazepines by competitively binding to the benzodiazepine site. In cases of suspected benzodiazepine overdose, flumazenil effectively competes with and displaces other benzodiazepines at the receptor site. As a result, flumazenil reverses the anxiolytic, sedating, and motor effects caused by benzodiazepines. In large doses, flumazenil can produce anxiety, increases in muscle tone, and convulsions, effects opposite to those produced by other benzodiazepines. p. 115 figure 4.10 PET image showing decreased neural activity throughout the brain after benzodiazepine. Benzodiazepine treatment. Red and orange colors indicate more neural activity than the yellow, green, and blue colors. Color version available in plate section. Source, copyright American Psychiatric Publishing, Inc. Side effects of benzodiazepines. Because the benzodiazepines cannot open Cl channels on their own, as do the barbiturates, they are less likely to contribute to respiratory depression. Lethal overdose by benzodiazepines is therefore quite rare unless combined with alcohol or another GABA agonist. In combination with alcohol, the benzodiazepines can cause a serious and sometimes fatal interaction by enhancing GABA neurotransmission. Other side effects of these drugs include marked sedation, cognitive impairments, retarded motor movements, and slurred speech, all effects observed with barbiturates and alcohol. When combined with alcohol, the benzodiazepine rohypnol, flunitrazepam, produces euphoria, sedation, and amnesia. Because of these effects, rohypnol has allegedly been used to facilitate date rape in a number of sexual assault cases. Prior to 1998, the drug rohypnol, which is used in England and Mexico for the short-term treatment of insomnia, was colorless, tasteless, and could rapidly be dissolved in drinks. Consuming this cocktail would bring about sedating and amnesiac effects within about 15 to 20 minutes. Since 1998, a blue dye has been added to alert one to the presence of this drug in spiked beverages. Nevertheless, the FDA has not approved rohypnol for use in the U.S. When used for the extended treatment of insomnia, the benzodiazepines disrupt normal sleep cycles and REM sleep, and discontinuation may cause rebounds in REM sleep, insomnia, and in anxiety. These effects are mediated by benzodiazepine receptor downregulation. Tolerance and dependence, also mediated by the downregulation of benzodiazepine receptor sites, occurs rapidly and may make discontinuation difficult for many patients. Although long-term use may cause physical dependence, there is little evidence from either human or animal studies that the benzodiazepines are addictive. This conclusion may be somewhat surprising since both benzodiazepines and alcohol share similar mechanisms of action. Perhaps the addictive potential of GABAergic drugs depends on how rapidly they enter the brain and on their ability to significantly increase dopamine activity in the mesolimbic system. The benzodiazepines are absorbed relatively slowly when compared with alcohol. In support of this hypothesis, the self-administration of benzodiazepines by laboratory animals is both variable and non-robust when compared to other abused drugs. Griffiths et al. 1991. A high rate of drug self-administration by animals is considered to be a reliable method of determining a drug's addictive potential. p. 116. In summary, the benzodiazepines represent a significant advance in the pharmacological treatment of anxiety disorders, seizures, muscle spasms, and insomnia compared with their predecessors, the barbiturates. All benzodiazepines agonize GABA neurotransmission by their activity on specific sites on the benzodiazepine receptor complex. Increases in inhibitory GABAergic activity decrease the firing rate of neurons in the frontal cortex, the hippocampus, and limbic structures assumed to underlie anxiety disorders. The benzodiazepines are safer than their predecessors and are rarely lethal by themselves in overdose. Their side effects are essentially the same as alcohol intoxication and the barbiturates, including sedation, cognitive impairment, retarded motor activity, and slurred speech. Although the benzodiazepines can cause physical dependence with long-term use, they have little or no addictive potential. Third-generation anxiolytics, partial GABA agonists. In attempts to minimize the side effects of sedation and cognitive impairment associated with the benzodiazepines, a number of partial GABA agonists have been investigated. A partial agonist has a high affinity for the GABA receptor, but has much less of an effect on the ability of GABA to bind than do full GABA agonists. As you may recall, GABA agonists alter the configuration of the GABA receptor slightly, thus making it more structurally compatible for GABA. Partial agonists appear to produce even more subtle structural changes than do full agonists such as the barbiturates and benzodiazepines. Several partial GABA agonists have been investigated but are no longer being pursued for use in the US. These include etazolam, which is available in Europe, imidazinil, vazinaclone, and bridazenil. In both human and animal studies, these drugs appear to have similar anxiolytic effects, but lower sedative and cognitive impairing effects than do the benzodiazepines. In addition, they appear less likely to induce tolerance and dependence. Mirza and Nielsen, 2006, Pina et al. 2006, Sana et al. 2005. The reasons for pharmaceutical companies not pursuing these alternatives aggressively may be due in part to the increased interest in SSRIs for treating anxiety disorders. However, interest in partial GABA agonists has continued with the development of several drugs used to treat insomnia. Serotonin 5-HT1A agonists. Because serotonin receptors are located through the brain regions known to be involved in anxiety, it should not be surprising to learn that serotonin agonists have anxiolytic properties. Genetically engineered 5-HT1A knockout mice lacking 5-HT1A receptors in the hippocampus, the amygdala, and the frontal cortex demonstrate exaggerated fear and anxiety compared to normal mice when tested in an elevated maze. Overstreet et al. 2003. In addition to increased behavioral anxiety, these mice have elevated autonomic activity, including increased heart rate and body temperature analogous to that observed in anxious humans. Injections of diazepam do not eliminate these stress responses, suggesting that interactions between GABAergic and serotonin 5-HT1A receptors are involved in anxiolysis. Albert et al. 2014, Salata et al. 2013, Padage et al. 2002. Although several 5-HT1A agonists have been shown to have anxiolytic effects, buspirone is the only one approved for anxiety at this time. p. 117 Buspirone, Buletinspar. Buspirone is a member of the azaparone group of 5-HT1A partial agonist drugs that were originally developed for their potential as antidepressants. And, although buspirone is used occasionally for the treatment of depression, it has not been approved by the FDA for this use. Buspirone is an effective anxiolytic, however, which has been established in numerous human and animal studies. In an extensive review of 36 clinical trials involving nearly 6,000 participants, buspirone was shown to be more effective than a placebo and as effective as benzodiazepines in treating generalized anxiety disorder. Sick et al. 2006. The agonistic effects of buspirone on HT1A receptors result in downregulation or desensitization of these presynaptic autoreceptors and a corresponding increase in serotonin synthesis and release. Hensler, 2003. Typically it takes 2 or 3 weeks for buspirone to become effective, a time course similar to the adaptive changes observed in serotonin receptors. Because of the delay in its therapeutic effects, buspirone is not as useful as the benzodiazepines for treating acute anxiety. Buspirone is typically better tolerated than benzodiazepines and causes less sedation and fewer cognitive and motor inhibiting effects. Additionally, buspirone does not cause dependence and there is no evidence for an abuse potential. GABAB and GBH receptor agonists. Gamma hydroxybutyric acid, GBH, is only discussed here because of its historical significance and the recent discovery of a GBH receptor, not because it is currently used as an anxiolytic drug. In the 1960s, GBH was used in general anesthesia, as an anxiolytic, and as a sedative for the treatment of insomnia. More recently, GBH has been used recreationally and in athletics to enhance muscle growth through increased synthesis of growth hormone. In some cases, GBH has been reportedly used as a potent hypnotic to facilitate rape. Because GBH is odorless and colorless, it is difficult to detect and it could easily be dissolved in beverages and consumed without detection. GBH is also difficult to detect in urine samples, so the incidence of its use as a date rape drug remain largely unknown. Because it is now restricted, GBH used to facilitate rape is presumed to be quite rare. Gamma hydroxybutyric acid is a naturally occurring metabolite of GABA found in small amounts in both plant and animal tissues. Until quite recently, GBH was believed to exert its sedating effects solely through the GABA metabotropic receptor, a less common form of the GABA receptor distributed throughout the brain and spinal cord. It is now known that GBH also binds to a separate and specific presynaptic G protein coupled receptor, GBHR, that regulates adenyl cyclase activity and ultimately neurotransmitter release. Carter et al. 2009, Sneed, 2000, Tiku et al. 2008. At present there is no consensus about whether the behavioral effects of GBH are mediated by GABA receptor agonism, the newly identified GBH receptor, or a combination of both. p. 118. Alternatives to drug therapy for anxiety disorders. The treatment of anxiety disorders with non-traditional pharmacotherapy has a long and controversial history. Although dozens of herbal remedies for anxiety have been utilized, only valerian and inositol are discussed here because there is some scientific evidence for their effectiveness. Valerian, Valeriana officinalis. The herb valerian, which is extracted from the root of the valerian plant, shown in figure 4.11, has a history dating back to Hippocrates, who may have been the first to describe its sedating and anxiolytic properties. Controversy about the evidence for these effects continues to the present. This controversy will continue until research on valerian is replicated by well-controlled clinical trials. The majority of the literature on the effectiveness of valerian has been either promoted by the herbal supplement industry or has been based on poorly designed studies or anecdotal evidence. Figure 4.11 Valeriana officinalis. In a recent review of the research on the anxiolytic effects of valerian, researchers Miyasaka et al. 2007, found that only one study utilized random assignment of subjects into treatment conditions and included a placebo control. In this particular study, patients were randomly assigned to one of 3 treatment groups receiving valerian, diazepam, or a placebo. After 4 weeks of treatment, the groups receiving valerian and diazepam scored lower on a subset of questions allegedly measuring the psychic symptoms of anxiety as measured by the Hamilton Anxiety Scale compared to the placebo group, questions 1 to 6. In figure 4.12. These results were confounded, however, by the fact that overall Hamilton anxiety scores decreased in all 3 treatment groups. Andreattini et al. 2002. suggesting that both valerian and benzodiazepines were no more effective than a placebo, at least in these patients. The relative lack of well-designed clinical trials, as well as reliable measures of anxiety in humans, continues to make conclusions about valerian's effectiveness difficult at best. Additionally, there are few objective studies that examine valerian's effects on inhibitory avoidance or forced swimming in experimental animals. As we saw earlier, animal studies are particularly useful in corroborating human studies when outcome measures are largely subjective. p. 119. Figure 4.12 Hamilton Rating Scale. According to Hamilton, questions 1 to 6 address psychotic anxiety while questions 7 to 14 address somatic anxiety. Source: Hamilton, 1959. p. 120. In the author's laboratory we isolated several active compounds in the valerian root extract, including GABA and valerianic acid. We compared the effectiveness of valerian with the known anxiolytic diazepam and samples of the active compounds extracted from valerian root using the elevated plus maze. In this study, female rats were randomly assigned to receive either an injection containing valerian root extract, diazepam, or saline. Additional groups received either valerianic acid or valerianic acid and GABA in the concentrations titrated from the valerian root extract. After 30 minutes, these animals were placed in the center of the plus maze suspended 4 feet above the floor. The time these animals spent exploring open arms of the maze is shown in figure 4.13. In this experiment, valerian extract was as effective as diazepam in increasing exploration. A measure of a drug's anxiolytic effects, Murphy et al. 2010. Figure 4.13. A comparison of the anxiolytic effects of valerian root extract, diazepam, valerianic acid, and valerianic acid with GABA in female rats using the elevated plus maze. Source: Murphy et al. 2010. p. 121. Mechanisms of valerian action. Despite the fact that research on valerian's anxiolytic properties is fragile, evidence that the herb acts as a GABA receptor agonist suggests that valerian at least has anxiolytic potential. Specifically, valerian, and its main constituent valerianic acid, were both shown to induce neuronal inhibition in experimental animals in a manner similar to, but slightly less potent than, the GABA agonist muscimol, see figure 4.14. Valerian apparently potentiates the inhibitory effects of GABA by binding to specific subunits on the GABA receptor complex, Com et al. 2007, UN et al. 2004. Whether the neuronal inhibiting effects of valerian are sufficient to produce an anxiolytic effect in people remains to be demonstrated in clinical studies. Inositol is a natural isomer, a molecule made up of the same elements as another but in a different structural arrangement, of glucose, and it is a precursor to several of the phosphate-based second messengers, shown in figure 4.15. Found in a variety of foods including bran cereals, nuts, and fruits including oranges and melons, inositol, inositol, is also synthesized by the body and is a member of the vitamin B complex. Inositol has been reputed to treat panic disorders, generalized anxiety, OCD, and depression. Evidence for these effects is sparse relative to the abundance of research supporting the effectiveness of traditional anxiolytic drugs for these disorders. A few studies have shown inositol to be more effective than a placebo and as effective as fluoxamine, an SSRI, in treating panic disorder and in reducing the severity of anxiety as measured by the Hamilton Rating Scale, Benjamin et al. 1995, Palachnik et al. 2001. Why the researchers did not compare inositol with either barbiturates or benzodiazepines is unclear. As with valerian, inositol research often lacks the kinds of scientific rigor which makes conclusions about its effectiveness speculative. Furthermore, The mechanisms of action that underlie the putative effects of inositol have yet to be described, although inositol is involved in second messenger systems in many neural pathways including serotonin. Figure 4.14% decrease in neuronal activity in rat brainstem following treatment with the GABA agonist muscimol, valerian, or valerianic acid, VA. Source, UN et al. 2004. p. 122. Figure 4.15. Inositol, C6H12O6, is a structural isomer of glucose, C6H12O6. In summary, alternatives to drug therapy for anxiety disorders have been proposed and some experimental evidence supports their use. Evidence described above using animal studies suggests that valerian may be effective, and the mechanism of action of valerian on GABA receptors is at least consistent with his alleged anxiolytic effects. However, the glucose isomer inositol has limited experimental support for treating anxiety, Mukai et al. 2014, and its mechanism of action remains elusive, although inositol does function in the second messenger systems of most neurons, including neurons that are known to underlie anxiety. Because neither of these substances cause significant side effects, or interact measurably with other anxiolytic or antidepressant drugs, their sensible use is not discouraged. In fact, as a first treatment attempt they might not only be effective, but they are better tolerated and cause appreciably fewer side effects than prescription anti-anxiety medication. Obsessive-compulsive disorder, OCD. Obsessive-compulsive disorder is a disorder characterized by recurrent, unwanted thoughts, obsessions, and repetitive behaviors, compulsions. Obsessions may consist of thoughts of contamination or infection, repeated self-doubt, a need for order, aggressive impulses to hurt someone or shout out an obscenity, or sexual imagery. Compulsions, which may include hand washing, counting, checking, cleaning, or hoarding miscellaneous items, are often performed with the anticipation of preventing obsessive thoughts or making them go away. Performing these repetitive behaviors appears to only provide temporary, if any, relief. Not performing these behaviors, however, tends to increase one's anxiety and obsessive thoughts. Patients with OCD recognize that their obsessions and compulsions are excessive and unreasonable, but this recognition does little to subdue their anxiety. OCD typically emerges in early adolescence or adulthood, but it can occur in children. The lifetime prevalence of OCD is about 2.5% of the population, and over 2 million people suffer from it at any given time. The prevalence of OCD is about equal for males and females, but may be more prevalent among males in the child population. The majority of patients with OCD experience cycling periods with and without symptoms, and experience the most debilitating symptoms during times of stress. p. 123. The DSM-5 criteria for a diagnosis of OCD are as follows. 1. The presence of obsessions, compulsions, or both. Obsessions are recurrent and persistent thoughts, impulses, or images that mark anxiety or distress. In addition, these obsessions are not simply worries about real-life problems, and the patient realizes that the obsessive thoughts are a product of their own mind and not imposed by another. Compulsions are repetitive behaviors that the person feels driven to perform and are aimed at preventing or reducing distress or some dreaded event. 2. The obsessions and compulsions cause marked distress, are time-consuming, and they significantly disrupt a person's normal routine, occupational functioning, and their social activities. Carl, a 24-year-old college student, began seeing a psychologist at his girlfriend's request because of his persistent checking behavior. Once they began living together, she was shocked by his inability to sit through a television show, a complete dinner, or even a conversation without getting up to check to be sure the kitchen stove was off or to lock the door to their apartment. During the night, Carl would often get up to verify that everything was off and secure. Carl even insisted that they leave the theater in the middle of a movie because he was certain that the door to their apartment was left open. reassuring him that she had checked was of little use once he began obsessing about it. Carl's obsessions appear to have begun in high school when he became obsessed with arranging and rearranging things in his room. At first his parents encouraged his cleanliness and the order of his personal things. When he went off to college they assumed his behavior would change in the presence of roommates who would likely be much messy than he. While Carl wasn't obsessed with the disorder of their shared dorm room, his obsessions about his own possessions persisted. Carl was meticulous about the folding and the order of clothes in his small closet and drawers. He also became concerned about the shared sink in their room. He spent hours washing and disinfecting the shared area where his roommate shaved and brushed his teeth. Any amount of hair or toothbrush splatter in the sink or on the counter repulsed him. After several months, Carl was granted a request to move into a single dorm room. In his single room, Carl was aware that his excessive concern about order was unusual. He was even embarrassed when others commented about how clean and orderly everything was. At one point, prior to friends coming to visit, he actually disorganized everything to make his dorm look normal. Carl found this to be so distressing that he spent their entire visit rearranging again rather than playing cards. Living in the shared space of dormitories was getting more and more difficult for Carl. His obsessions over the sanitary conditions of the showers, the many doorknobs, and the shared kitchen space distracted him much of the time. He was also concerned about leaving his dorm room door unlocked and needed to check it frequently throughout the day. By his senior year, Carl had moved into a small but new apartment. Within a few months his girlfriend joined him only to be stunned by his unusual behavior. After 2 visits to the university psychologist, Carl was referred to a psychiatrist at the university hospital for medication. Following a brief visit, Carl was prescribed Zoloft, which he continues to take today. His obsessive symptoms of anxiety have improved, but his ritualistic checking has not. Carl's symptoms seem to come and go over time and are most severe when he is under stress. p. 124 Assessment of Obsessive Compulsive Disorder. One of the most common assessment tools for diagnosing the severity of OCD is the Yale-Brown Obsessive Compulsive Scale, YBOCS, Goodman et al. 1989. This 10-item scale is presumed to measure both obsessive and compulsive symptoms. It is mentioned here because it is often used to evaluate the effectiveness of treatment, medication, as well as the effectiveness of cognitive behavioral therapy. Researchers are also interested in developing animal models of OCD to study its underlying pathology, as well as to investigate drug effectiveness. Several animal models have been proposed that involve inducing OCD symptoms with drugs, e.g. quinpirole, which increase dopamine activity in the striatum and produce compulsive checking, like and hoarding behaviors in animals, e.g. Eagle et al. 2014, Fernandez, Guasti et al. 2003, Joel, 2006, Zekman et al. 1998. Drugs that effectively decrease OCD. Symptoms in human patients appear to diminish OCD, like symptoms in animals as well. Pathology of obsessive compulsive disorder. Of all of the anxiety disorders, OCD has the clearest connection to abnormal neuroanatomy and function. The prevailing view of OCD argues that it is a biological disease involving neural dysfunction in circuitry between the orbitofrontal cortex, the cingulate gyrus, the caudate nucleus, the globus pallidus, and the thalamus. This neural circuit forms a loop where dopamine hyperactivity in the caudate nucleus inhibits the globus pallidus, which normally suppresses thalamic activity, illustrated in figure 4.16. Excessive dopamine inhibition in the globus pallidus is presumed to disrupt the normal inhibitory control the globus pallidus has over the thalamus. Increased activity in the thalamus of OCD patients produces increased activity in the orbitofrontal cortex via the cingulate gyrus. This proposal is supported by several neuroimaging studies, Saxena et al. 1998, and volumetric studies of these structures, Atmaka et al. 2007. Furthermore, OCD patients who had been successfully treated with SSRI medication showed normalized functioning in the caudate nucleus compared to patients treated for depression, Saxena et al. 2003. A number of patients with severe OCD have benefited from surgically disrupting the excitatory input from the cingulate gyrus to the frontal cortex by a procedure known as a cingulotomy, which severs this connection. Surgical intervention is only an option when patients don't respond to medication, e.g. Sheth et al. 2013. Pharmacological treatment of obsessive-compulsive disorder. The observation that symptoms of OCD are dissipated with serotonin agonists, SSRIs and SNRIs, has led to the hypothesis that serotonin dysfunction underlies this disorder. It is important to note, however, that there is little evidence for serotonin dysfunction in OCD, Westenberg et al. 2007. There is also little agreement about which serotonin receptors may be involved when symptoms are improved, Lin, 2007. It does appear, however, that it is serotonin reuptake inhibition that mediates the effectiveness of treatment, even with the dual serotonin, norepinephrine reuptake inhibitors. A number of these drugs are described in Table 4.3. There is a growing consensus that serotonin agonists are initially effective in 50 to 60% of OCD patients. Non-responders may eventually respond to another serotonin agonist or to combinations of drug and cognitive behavioral therapy, Simpson et al. 2013. p. 125. There is no text on this page. Figure 4.16 Neural structures implicated in OCD, top. Normally, thalamic activity suppresses activity in the orbitofrontal cortex via the cingulate gyrus. In OCD, hyperactivity in the caudate nucleus suppresses inhibitory input from the globus pallidus to the thalamus. This results in an increase in activity in the thalamus, cingulate gyrus, and orbitofrontal cortex, bottom. Patients who respond to treatment with serotonin agonists also reveal decreases in blood flow to the thalamus compared to patients who don't respond to drug treatment, a finding consistent with thalamic hyperactivity contributing to OCD symptoms, Ho P. et al. 2005. Treatment with the serotonin agonist fluvoxamine has also been shown to increase dopamine, D2, receptor availability in the caudate nucleus. This secondary effect of serotoninergic activity is presumed to normalize hyperexcitability in the caudate nucleus and the thalamus, Moresco et al. 2007. p. 126. Table 4.3 FDA-approved medication for the treatment of OCD. Other serotonin agonists may be equally effective, but are used off-label. In conclusion, OCD is a serious and debilitating condition that affects a significant portion of the population. Disruptions in neural circuits between the caudate nucleus, globus pallidus, and the thalamus appear to cause increased activity in the cingulate gyrus and the orbitofrontal cortex. Evidence supporting this hypothesis comes from numerous imaging and surgical studies, as well as animal models of OCD. While there appears to be evidence for a genetic contribution to OCD, there is little agreement on the details of its underlying pathology or on the details of serotonin involvement. Drugs that increase serotonin activity, however, do effectively decrease symptoms in many patients, and they appear to normalize hyperexcitability in the caudate nucleus and the thalamus. Post-traumatic stress disorder. A significant number of individuals who experience severe stress associated with a disaster, an accident, military combat, rape, or who witness a horrific crime may continue to experience stress and anxiety through intrusive memories or dreams of these traumatic events. About 11% of the rescue and recovery workers after the 9/11 attacks on the World Trade Center in New York continue to be traumatized by their memories, and many of these individuals could not continue to live and work in New York City. About 9% of the population, over 24 million people, in the US will experience post-traumatic stress disorder at some point during their lifetime. The DSM-5 lists the following criteria for a diagnosis of post-traumatic stress disorder, PTSD, p. 127. 1. Exposure to actual or threatened death, serious injury, or sexual violence by directly experiencing it or witnessing it as it occurred to others. 2. The traumatic event is persistently experienced as intrusive recollections, dreams, or flashbacks. 3. Persistent avoidance of stimuli associated with the trauma indicated by efforts to avoid thoughts, activities, places, or people associated with the event. 4. Negative alterations in cognitions and mood associated with the traumatic event. 5. Marked alterations in arousal and reactivity associated with the traumatic event. 6. These disturbances have occurred for at least 1 month and cause significant distress or impairment. Impairment in social, occupational, or other areas of functioning. Pathology of post-traumatic stress disorder. Stress causes profound changes to structures in the brain that regulate fear and anxiety. Among these changes are significant decreases in both hippocampal and prefrontal cortex volumes and an increase in dendritic density and activity in the amygdala. The decreases in hippocampal volume, particularly in the region of the dentate gyrus, are a result of increased glucocorticoid and catecholamine release during the stress response. Decreases in the volume of the medial prefrontal cortex may also be related to increased glucocorticoid and catecholamine activity. As a result, stimuli associated with traumatic events cause enhanced amygdala responsiveness that is not suppressed by cortical inhibition. Recent functional neuroimaging studies confirm that the medial prefrontal cortex is hypoactive in PTSD patients. Additionally, PTSD patients demonstrate heightened responses in the amygdala following exposure to trauma-related stimuli. Carl et al. 2006, Miller et al. 2006, Shin et al. 2006. It is believed that heightened amygdala responsiveness to emotional stimuli and hypoactive inhibitory input from descending prefrontal cortical regions underlies post-traumatic stress disorders. Evidence for decreased GABA inhibitory activity in PTSD patients comes from a recent study comparing the ability of the GABA antagonist flumazenil to bind to GABA receptors in PTSD patients with normal control subjects. Radioactively labeled 11C. Flumazenil was injected into both groups of subjects and measured using PET scans. Significantly, decreased densities of GABA receptors were found in PTSD patients. See Figure 4.17. Figure 4.17. Areas with decreased GABA receptor binding in PTSD patients are indicated in yellow. Color version available in plate section. Source, Jis et al. 2008. p. 128. Animal studies also confirm that stress hormones and the catecholamines contribute to neuronal atrophy and degeneration in the hippocampus, whereas stress manipulations cause enhanced dendritic branching and growth in the amygdala. These structural changes lead to enhanced emotionality in laboratory animals and seem to parallel those changes observed in humans with PTSD. Bramner, 1999, Denlowski et al. 2012, Vyas et al. 2002. Glossary Amytal interview and interrogation of a witness after the administration of sodium amytal, truth serum. Evidence obtained under the influence of such drugs is not admissible in court. Anxiogenica, a drug or substance that induces or exacerbates anxiety. Anxiolytic, a drug or substance that is used to treat anxiety. Cingulotomy, surgically disrupting the excitatory input from the cingulate gyrus to the frontal cortex. Occasionally used to treat drug-resistant obsessive-compulsive disorder. Convulsant, a drug or substance that can induce seizures or convulsions in subjects. Cross-tolerance, tolerance developed to one drug may be expressed to other similar, acting drugs that the patient has not had before. Elevated maze, an apparatus used to evaluate the effects of drugs on anxiety responses in laboratory animals. Designed with two enclosed end 2 open arms and suspended about 3 feet above the ground. The proportion of time spent in open arms is a measure of a drug's anxiolytic effect. Fetal alcohol syndrome, a severe developmental disorder caused by fetal exposure to alcohol or other similar, acting drugs. Generalized anxiety disorder, chronic worry about events with no specific threat. Characterized by restlessness, fatigue, difficulty with concentration, and sleep disruptions. Inositol, a derivative of the glucose molecule with putative anxiolytic properties. Obsessive compulsive disorder, OCD, a severe psychological disorder characterized by the persistence of unwanted thoughts or disturbing images. Compulsive, often ritualistic, behaviors may also occur in attempts to mitigate the obsessive thoughts. Panic disorder, experiencing repeated and unexpected panic attacks as well as anxiety about impending attacks. Partial agonist, a drug that binds to and agonizes a receptor but with less intensity than a full agonist. Post-traumatic stress disorder, PTSD, a severe stress disorder brought about by an extreme traumatic experience. Valerian, a herbal remedy promoted to treat insomnia and anxiety. Derived from the root of valerian plants. P. 129. 5 Psychotic disorders. Schizophrenia. David was first diagnosed with schizophrenia when he was 26 years old. At that time he was in his 4th year as an architect student at the University of Oregon.